I'm going to try and lift this up a little bit more, and I'm going to try and talk to you about what I think it means to be a GP in this new way of working and in this new system going forward. So that's just a little bit about who we are in Dorset. So we're a big county. We were one of the CCGs that took clinical commissioning services in-house into our CCG. We were the third largest. We comprise 3 acute trusts, 1 community trust, which also is a very large mental health trust, of 1 big ambulance provider. We had 101 practices when we started as a CCG, and we're now 86 practices, not because we have forced anyone to close, but because of the pressures on general practice have been very acute in Dorset. Even in this very, very nice place to work, it's quite difficult in some areas to recruit because we have some very challenged areas of deprivation. We have some very lovely leafy areas. And to the west of our county, it's very, very rural. And to the east, we've got Bournemouth and Poole, entirely different populations, very, very much denser. And our total population is now around 800,000 people. We've got a big budget, and we're working very, very hard to think about how we transform care going forward and what that means for primary and community services. Before you take anybody with you on any journey of change, you have to really clearly identify what is it that's wrong in your system. Why do you need to do anything different? And I've kept coming back to this all the way through my particular journey, leading on both acute, community, and now primary care transformation. Because you'll take nobody with you if you don't really understand what are the inherent problems within our system. So we identified these areas very, very early on. And there were everything from variation to difficult access. Of course, the demographics, and the demographics the same everywhere. We've got increasing need, older population, increasing long-term conditions. And we need to find a way of working to serve those populations. But we've in Dorset had particular workforce shortages, and that wasn't just around general practice, although we know that around 30% of our GPs were set to retire in the next 5 years. And we've got a very old demographic of GPs and also practice nurses, which is really, really concerning as well. When you start, I'll talk to you through the model of care that we've been starting to design. But that made it even more pressing that we did something different, because we had a very disillusioned, very tired workforce. And we've also got some real problems in some of our acute services as well. So we've got specialities who are really, really struggling. Finance was a real reason for doing something different. We were looking at a big financial gap. And then when we started to look at things, we found that lots and lots of our community services were really underutilised. So when I was doing some community reorganisation and reconfiguration work, I went round 13 community hospitals, or a number of them. And, you know, I would go to 3 physio gyms and see not one patient, and huge swathes of opportunity really within community services to do something different and try and reduce waste and put the money into something different. So in line with many other sustainability and transformation plans, we built a vision of how we were going to transform services, building on what we do in the acute services, top of the triangle. Not many people go to hospital in their lifetime, actually, in reality. Thinking then, and I'm very involved with the tier 2, which is about how do we transform community and primary care services to fundamentally underpin that whole system. You know, general practice fails, the whole system fails. It absolutely, genuinely does. So how do we shore that up and work with partners and not ask general practice to do it on its own, because this is not about a siloed way of working. Then we built in prevention at scale. It's been really important working with our local authority partners, public health partners, thinking about how do we support, generally speaking, people within a primary care setting. And then there were 2 key enablers to that. One was everybody said to us when we started on this journey, you've got to make us all digitally enabled to see each other's record, to do the right thing. And we've been on a real journey about how do we improve that and improve that technology? And then how do we lead and work differently? What is it that we have to do within our organisations to start thinking about how we do that? So our care models changed from a very hospital-centric service to community-based teams. This is all the visioning was done with GPs, with hospital consultants, with managers in support. We spent many months trying to work through what this might mean, moving to care that was completely within general practice, to think about how we use different teams, thinking about how our practices started to work together for it to create a resilient way of working. And we heard this morning about how you go from a general practice to a group of practice to a network of practices to improve that scale and see what you can deliver at those different levels. And then it moves all the way up to a greater number of providers together and thinking then about what our integrated care system looks like as a whole and how we start to use the acute services, the community services, your mental health services, your local authority partners. We're working with transport providers to think about how we get people in and out of rural settings. And suddenly you can start working with schools, your education facilities. We're starting to talk to many different people about how we grow our own workforce. And suddenly you start to be able to think differently about health is not health on its own. Health is part of a much wider system. So our transformed care model looks like this, and again, many of you will have seen this sort of thing in many different ways, but we started to think about if our demographics were changing and if our long-term condition management was changing, how would we look after these people with the same workforce, knowing the workforce challenges that we had? And so we designed and looked at our most complex group of users, who it might be that looked after them if it wasn't just the GP on their own. And then we started to think about the teams of specialists that would do that. So if you brought in your community matrons, your consultant where needed, your social care workers, your healthcare assistants, and you started to build teams around specific groups of patients, what might that look like? And then we started to think about, well, what would that workforce design start to look like? And then you start to think about the care models actually directly influencing who you might think about taking on in your practice, how you would deliver care in a different way, using not just your practice, but a group of practices. And then thinking about what the wider offer is in community services. So we've really done a lot of thinking about the different settings of care for different groups of population. Not that you take them out of your practices, because everyone will be continuing general practice as you are now, but there are groups of people who it really makes sense to look after in a slightly different way. And we're working our way through these very reactive teams to people with very complex care needs, thinking about the proactive and holistic anticipatory care approach to people who are in the rising frailty and rising group need, the people that take 80% of the funding for about 20% of the population, thinking about how we look after those people, and then extrapolating that to then how do we look after people with long-term conditions to get better outcomes, and then thinking about the bottom end of the spectrum, thinking about urgent care. Many people said to us, we don't actually mind who we see. If we've got a sick child or an earache or a urine infection or something, we actually just need to see someone quickly, and continuity is not a problem. So we started to think about this around 3 years ago and then started to look at how we would manage these populations. And so our strategy, and you'll hear a lot about the AAA, which is about care and quality and new care models, and finances, which are all really, really important. But then we put in here at the bottom is the quadruple aim, which is all about how you make your workforce able to work in this very, very challenged system. How do you increase your resilience? How do you make this a happier place for doctors to work in? And we have seen by changing the way that we're working in various situations that we are now able to attract doctors to come in. We've got regularly people from other areas wanting to come into our systems because actually they hear about it and they think it might be actually a better way of working. So starting to attract people and workforce in. But as a GP, this is all really important, because what I want for my patient is I need to be able to look after them properly. I need enough time to be able to do that. I want to be sure that we're addressing unwarranted variation. I want to be sure that I'm addressing need, and I work in a very deprived population. So life for me as a GP is really not easy. But I want to be sure, and we've never really taken a hold of how do we look after the more deprived populations? What is the additional investment that we need to put in there to actually make that possible for those very stretched services around those patients? And then you start thinking, and I'm going to try and bring it back up to system level again, which says, as a system then, how do you move the resources around? And I choose that word carefully, because it's not always very easy to move money around a system, but what you can do is move resources around a system. You can move people around a system. You can move skills around a system. And that starts as a GP then to be You're the kernel and nugget of the care, and then around you there are spreading circles of expertise from other directions that we can really tap into to help us to be able to deliver care in these different ways. And as a commissioner as well, I have the added luxury then of being able to try and align the financial incentives. So then I've started to work with our very talented teams, finance, managerial teams, to try and help align incentives that drive a different care model. So we talked about the over 75s money that was put in a few years ago. We've rebadged it as a frailty, so it's an enhanced service for frailty, and it's about working with partners to be able to deliver care in a different way that's a more multidisciplinary and holistic way of working. Busy slide, it talks about on our journey forward for around general practice, we talk about what's the investment, what's the workforce, how do we improve life for our workforce, what's the infrastructure, the estates and the IT and so on, how do we address the workload and the transformation team here, and you'll have heard before, it's all of the 5-year forward view and the high impact changes. And then we overlay their care redesign in the way that I've already described about actually how do we do this? How do we look after people in a different way around each of those segments of the population? So bring it down to a locality. So I'm also a locality chair. So I now work, this is what we do, this is how we started to do it. In every area we'll do it differently. These are my thoughts. We look at what our local population needs. We have local public health profiles that dig deep and tell me, you've got high smoking, you've got high pregnancy, high smokers in pregnancy, you've got high rates of cardiovascular disease, and those locality profiles exist for the whole of our patch. So we can start to think about what we need to do differently. We started to work at scale together, so our 8 practices now meet monthly, regularly, to go through how we're going to transform ourselves. So I'm not telling any group of practices that they need to work in a different way. I ask them to come up with the ideas themselves to take some ownership of general practice and how that might change. So we meet monthly. I have a prescribing lead, I have a deputy, and I have a member a GP from every practice and a practice manager from every practice who have all started to take on a leadership role really within their practice and within the locality to help us to start to mould and shape the change. So we came up with a locality plan. And we've left people really to start thinking about what their issues are rather than what I'm going to tell them are their issues. So we've talked about everything from new ways of working, new care models, what integrated teams look like, how we're going to promote integrated nursing teams within our practices, think about workflow planning. We've now all practices have engaged in that training and now thinking about how to do it together for resilience. And then everything from estates to IT. So I really genuinely believe that to change and be part of this new system, we need GPs to be part of the solution and drive some of these areas forward. And there'll be many people in the room, I'm sure, who are really desperate to try and get on with some of this stuff. And then we started to embed the primary care home approach, and some of you will have heard of the primary care home approach, which is very fundamentally around how we build resilience by groups of practices working together around specific areas. So, and it has a really strong focus and there's a methodology to this, but we're working through how we create that integrated workforce of the future, how we personalise care and really think about population health improvements for our local populations, how we align the clinical and financial drivers to enable that to happen, and then starting to think about how we work together as groups of 30 to 50,000, this thing that everyone is talking about, but seems to be the right sort of scale. But it certainly is starting to, from my own experience, take GPs and practices that were very, very siloed, very individual. We don't want to change, thank you very much. But actually we recognise that there are some changes, and we're now on a journey of transformational change whereby practices are now starting to think about all the things that they can do together to support each other, whilst not being a super practice or a super partnership, but are definitely on the journey, an evolutionary journey. So some key areas that we've made progress on is particularly around frailty. We've developed through work we've done around a local hub, community hub, where we're trying to move services into the community, some toolkits for practices to start to use. And it talks about how you run an MDT, what a good anticipatory care plan looks like. How can you join that up so that everyone can see that? So some really practical things that start coming out of some innovative work that happens when you bring people together who just want to make things better. And so we've supported practice MDTs, so patients are looked after still, of course, within practices because continuity is so important, but then outreaching into a wider team so that there is good support for practices and GPs to do some of the more difficult stuff. We have a primary care workforce centre that works on all of our behalf to act as a resource for recruitment, for education and training. We have, in the last 4 to 5 months now, rolled out at least 50% of improved access to general practice over 7 days, which is remarkable from a standing start, really. We've got it up and running over the whole locality. Many areas have taken much longer. And we've done that because we've been able to work with partners to be able to do that, with our community partners particularly, to be able to do that. We've got improved collaborative working around a number of specialities. Diabetes is the one that's really becoming very prominent, where most of our diabetics we look after within practices, but some really difficult ones and challenging ones. We start driving an MDT approach, bringing in specialists from the hospitals, the community diabetic nurse specialists, theming around care homes, difficult patients, hard to reach, hard to manage. And now we've got paediatrics coming online, where we have paediatricians coming into the community delivering clinics, not just in a lift and shift way, but in enabling us to do some virtual clinic style and also improve teaching for mainly nurse practitioners who don't get this real teaching as they go through their development. And I've talked about each locality plan is supported by some transformation funds. So any money that we've had, we've not just put into a service. What we've done is we've given heads up time to GPs. So all of these meetings that I chair are supported by backfill into the practices so that people have got some real heads up space to do some real thinking about how they can then start to move services and change things. So, and that's been incredibly helpful. Without that, I don't think we would have made nearly as much progress as we have, and I've talked about primary care home. So I'm just going to give a couple of examples really about, so this is a local community hospital called West Haven, and we, about 2 years ago, without any investment and without a new commissioning anything, we just decided that we would bring health and social care together, and we would start to bring our community frailty teams together. And that's been really empowering for staff and for all who work really within that hub. So we look after the very complex patients, around 76,000. We take the top few percent who are the most sick in that region. And then as GPs, they're our patients. I look after my patients, but when I'm struggling, when I need some extra help, I refer into this hub. So if I have a deteriorating patient, instead of taking 3 hours to try and find domiciliary care or a social worker or somebody to look at my patient, I pick up the phone, a single point of access. I'm into the hub, there's a multidisciplinary team around who swirls into action and does, whoever picks up the call, manages the call, does the right thing, pulls a team around the patient, and is a very highly responsive way of working. So if you remember our top of the triangle and the complex care needs, this is it, and this is really what happens. And we have coordinators who work with the social care team, so everybody knows what everyone else is doing. And we found that actually using this outcome, the first year we had around 2,000 patients taken on as part of virtual wards. We have patients who are at home on a virtual ward. At any one time, there's 16 to 20 patients who are being managed in their own homes instead of being in a hospital bed. What does that mean? We have less people going into social care. We have less people going into the acute hospital. We have high patient satisfaction and carer satisfaction as a result of it. And now we're extending over a 7-day service for that. It's good for patients, it's good for the system, it's very good for us as GPs, and it's absolutely the right thing to do. We've completely changed the model of working so that in our community beds, which we can step up to, we've gone from 100% step down beds from an acute hospital to 50% step up. And that's amazing because I can get people into hospital for a few days rehab and then home. they don't suffer from the, all of the complications we know from long hospital stays, and it's helping to drive down length of stay as well. So a really practical example of actually sometimes just doing it, trusting others, working with other services around us as part of that integrated system to just do the right thing. This is our urgent care. So I've gone to the other end of the spectrum. This is our urgent care system, which was one of the Darzi systems centres that really was, in the end, after the 5 years of contract, was a very, very expensive minor ailments service. And we got a hold of it and thought about what it might mean in terms of improving that offer across 7 days. It's a big resource. How do we do that to try and help, again, a very, very constrained general practice around it? So we worked with partners. So it was a collaboration of the Acute Trust, Community Trust and General Practice Federation, who came together, won the contract, and then put in place an amazing service where we saw 34,000 the first year, 37,000. That's a huge amount of patients going through, which has enabled the whole system in that particular area to meet its A&E targets, because it's protecting the acute service from a lot of these people would have just gone up to A&E. Unlike the ED streaming type of triage, which is actually very superficial, we do very, very intense triage. That enables us to signpost back the complicated patients to where they should be in general practice. And it's allowed us to turn 10% of people back away without anything at all. You go to a pharmacy, you need to self-manage, you need to self-help, because we can't keep medicalising every condition that works through the door, that comes through the door. The system value is high, patient satisfaction is high, to GPs it's high, and we're starting to use this now to stream off. So my practice now streams off urgent primary care. We put the resource in, of course, to be able to manage that, and that now is a site for improved GP access through the improved access. And so it all makes sense, and in time, as we build our system, we'll be putting more diagnostics here, so we'll be able to manage more and more patients on this site, because we'll be putting the support services in, there'll be more therapies and so on, so there's a long-term plan. So I think these are just a few themes. I think they're my own reflections in terms of trying to transform care. You do need scale, you need evidence-based guidelines and standardised best practice. We have to keep a really close eye on prevention and not, as I've said, keep on medicalising. There's a lot that patients can do themselves. It's very important to align and recognise the financial levers and incentives that need to be in place. I think we're going to see a revolution in technology. I think we haven't even begun to scratch the surface of what we can do digitally and with technology. And I think much of what we struggle with, particularly in general practice, I think could be improved by different flows and business excellence. That's another whole talk. But I think we also need to think about how we use our workforce and how we redesign our workforce so that everyone is working to the top of their license. No one's doing anything that really they shouldn't be doing. And thinking about the consultant of primary care approach, which we're really trying to build with this way of working. And really importantly, and I haven't got time to talk about it in any detail, but I do believe that population health analytical data to help you understand what it is that you're doing at practice level, help you identify the patients that you need to be seeing, is really critically important. So I think new workforce models are tricky in general practice. I don't think any of this is easy, but I think we need to understand what each professional can do. And think about what flex you have and how much you trust someone coming into your system. When I took my paramedic on, I was slightly hysterical, thinking, will he do what I do? Will it be okay? How will I manage and trust him in that role? And I think we will, all of us, struggle to some extent with giving up some of that autonomy in the roles that we are providing. A year and a half down the line, with intense clinical governance and supervision and battling with the MDUs about how do we indemnify, my paramedic, or I bear the scars and the pain. It's really difficult. But 18 months down the line, I could not do without that person. He's invaluable in my service, in my practice, and he takes away much of the home visiting, which means that I can sit and actually have more time for complex care patients and a bit more time to just manage the burgeoning workload that we all face. I think we should be thinking about how we train together around problems. So thinking about, I run lots of protected learning times where we try and bring other people from other environments into our world to take that forward, and then focus on our better work-life balance, really. And I'll just leave you with a challenge, really, which is around a paper that Michael West wrote around the 4 fundamental elements for a culture of innovation and high quality care. I just want to leave you with this, really, which is about inspire and talk about your strategy, drive it forward because you're the leaders of your practice. You wouldn't be here if you didn't really want to change something and do something different. So really get a hold of this and be brave and be courageous about your view for the future. Be positive and inclusive. Think about enthusiastic teams and how you work across boundaries, and trust your staff to innovate and help you go forward.